Hi, I'm Dr. Pamela Morris, and I'm here at day 3 of the Women's Wellness Masterclass in Dana Point, California. It's my pleasure to be here with my friend and colleague, Dr. Jeff Barnes. He is Associate Professor of Medicine at the University of Michigan, and he is a vascular medicine specialist. And today he really entertained us and educated us with a couple of complex cases addressing those really high-risk patients who have concomitant both coronary disease and peripheral arterial disease. And really, we had a bit of a focus on sex-specific differences, the presentation in men and in women. And so what I wanted to start, Jeff, is just by talking a little bit, are there any sex-specific differences in how women experience PAD versus how men experience the symptoms?
Yeah, I think that's a really great question. And the truth is that PAD is often under-recognized in both men and in women. I think often women will have symptoms that they'll downplay because they'll focus on other aspects of their life, whereas men tend to just adjust their lifestyle so that they don't have symptoms. Either way, you really have to uncover that when you're seeing them in clinic. You have to ask about how far they're walking. Has that changed? Push them to say, if we walked a certain distance, would your legs hold up? And then take off those socks, look at their feet, palpate a pulse, see whether or not there's any sores or anything on the feet that might suggest that they have PAD that they aren't recognizing.
All right. In terms of diagnosing, is screening for pedal pulses enough? Or how do you know when to go on beyond just the simple physical exam?
Yeah, I love this question. We know from the guidelines that we should not be doing screening ankle brachial index or ABI tests on everyone. But it's a really important test to diagnose PAD when we have suspicion. And so the question is, when is suspicion there? And it's anyone who has important risk factors or signs and symptoms that you pick up. So for instance, in a patient who has known coronary disease and diabetes, maybe they're over the age of 50, they have several risk factors. We absolutely need to think about PAD. And so doing that really good foot exam, you're looking at the foot and you're palpating for those pulses. If you don't feel a really strong pulse, boom, that's a great patient to get an ABI test on to diagnose PAD.
One additional question I had to ask you was just in terms of the patient interview. What are the questions that you specifically ask a patient to be sure that you're teasing out claudication from statin-associated muscle pains versus yesterday's gym workout?
So when I'm looking for those claudication symptoms, I'm asking patients about how their legs feel when they're doing activity and differentiating that from how it feels at rest. So I'll often ask questions like, when you climb the stairs, do your legs start to ache? Do you feel some achiness or soreness in your muscles that gets better when you stop and rest? I'll ask them things like, when you're running around with your grandkids or when you're walking to the mailbox, or a really good one is if you're going to the grocery store and walking up and down the aisles, do you have to stop and rest because your legs hurt? Or are you able to walk at sort of a non-stop pace all the way through the aisles of the grocery store? Those are the kinds of questions I use to uncover symptoms, even when patients don't come in initially complaining about them.
So let's take a turn now and talk a little bit more toward management. Let's start with the basics of management.
Well, the most important thing you can do for somebody with peripheral artery disease is say, are they having symptoms that we need to alleviate? And if they're having lifestyle limiting symptoms, that's where we start thinking about some of the medications that can reduce the symptoms and some of the interventions, some of the revascularization pieces. But it's really important that you don't only focus on symptoms, because we know patients with peripheral artery disease have a very high risk of cardiovascular disease. That's especially true when they have a history of both coronary and peripheral artery disease. So it's really critical that they be on antithrombotic therapy, starting with aspirin, but probably going beyond that to dual pathway inhibition, meaning rivaroxaban, 2.5 milligrams twice a day plus aspirin. It's critical that we get these patients on high potency, high intensity statin therapy to lower their LDL. We know that smoking is incredibly common among people with PAD, and so anything we can do to help them quit smoking is really essential. And then trying to get that blood pressure under good control. Those are the things that we know can be very effective at preventing future cardiovascular and limb-related adverse outcomes.
And I had one question just following up on the rivaroxaban. We're taking care of very high-risk patients who have the combination of coronary disease and PAD. Not uncommon for these patients to then come back with recurrent cardiac events. The approach to triple therapy in these high-risk patients, you knew the question was coming.
Of course, this is always the question, right? And it's this balance between preventing future cardiovascular events and avoiding the complications of our antithrombotic therapies like bleeding. And so I really focus on using dual pathway inhibition in two groups of patients with PAD. The first are those who have stable peripheral and coronary disease, but they're high risk because of all those features we just talked about. What else can we do to avoid that future event? The second is in a patient who's recently been revascularized in their legs. We have very good data to tell us that dual pathway inhibition, that combination of rivaroxaban and aspirin, is a very effective strategy in those patients. When somebody needs to have a coronary intervention, and so we know they're going to need to be on dual antiplatelet therapy or DAPT, then you have to individualize for those patients. Sometimes it's a matter of saying, maybe we're going to put rivaroxaban away for a little bit while we focus on that potent P2Y12 inhibitor in addition to aspirin. But once the course of the P2Y12 inhibitor has finished, now we'll bring rivaroxaban back into the fold. Other patients who are at very low risk of bleeding, you might try and combine all three, but that can be a little risky just because of the bleeding risks.
Terrific. This has been a great discussion, Jeff. Thank you so much for being here.